Hi, I'm Dr. Keshav Malhotra. I'm the chair of the embryology SIG for Aspire, and today we're going to be talking about the different clinical results from PGT-A cycles. Today I have with me Jason. Jason, if you could introduce yourself a little bit and then we'll start with the topic.
Surely, it's a pleasure to be here. I'm Dr. Jason Fernasiak. I'm the lead clinician and laboratory director of the embryology and andrology laboratory of the EVR Mayo Clinic in New Jersey, and was asked to come and speak to the folks at Aspire on really kind of discussing PGT results and how to clinically interpret some of the various results that we get.
So Jason, like my understanding of PGT results is very basic. I would say that I would classify it as euploid, aneuploid, something that I can use, something that I have to discard, and that's generally the end of it. But I think the lecture that you presented yesterday was quite eye-opening in the sense that obviously we did speak about mosaic embryos and we did speak about challenges with mosaic embryos, but the interpretation of PGT varies from laboratory to laboratory. So let's speak about that for a little bit and then we'll come to the crucial points.
Sure. So, I think that historically PGT-A results have been binary. So you had either had euploid embryos or you had aneuploid embryos.
Yeah.
With the advent of next generation sequencing and the use of PGT, we have seen that there are now more diagnoses which have been put into place.
Yeah.
So you have the classic aneuploid and euploid, but you also have mosaic embryos, and that could be whole chromosome mosaic or partial chromosome mosaic. And then you also have segmental aneuploids. And so I think that one of the discussions that we need to have with our patients is how do we deal with these results? And even taking a step back from that, how do you think about how to utilize different PGT labs that are out there? Because there is data that exists that shows that different PGT labs have different results when it comes to the reports that they provide.
Yeah. So for the audience out there, could you basically explain these terms a little bit more? What is mosaicism? What is segmental aneuploidies? What is whole chromosome mosaics, partial mosaics, etc.?
So, mosaicism is a biologic phenomenon. It's having more than one karyotype in a single cell population. That is slightly different than mosaicism as diagnosed with PGT-A.
Yeah.
Mosaicism with PGT-A is intermediate copy number. And when you think about mosaicism with PGT, you have to remember that we're talking about 5 to 10 cells out of several hundred cells in the trophectoderm. So this intermediate copy number is trying to get at a diagnosis of having different populations of cells in that 5 to 10 cell population. Now, some of this could be true mosaicism, meaning there might be some cells that have one karyotype and another cell that has other karyotypes. It could also be due to assay issues. It might be due to contamination. It might be due to biopsy technique or loading. It could be due to a number of different things.
Laser shots.
So, I think that one of the things that we think about does have to do with the way that the biopsy is done, the tubing of the biopsy, and then also the time frame between the tubing of the biopsy and the analysis in the PGT lab.
So there's a lot of quality control that really needs to be put in to the laboratory for them to offer PGT to get a more clinically useful result, if I may call it that.
I would agree with that. And I think also we have to be thoughtful about the PGT lab itself.
Yeah.
I think that different PGT labs can have different results, and that comes down to the fact that each PGT lab or assay within the lab needs to be validated. And I think there are a couple of different steps when it comes to validation.
Yeah.
There's analytic validation and clinical validation. And once validation is complete, then you need to think about clinical utility. how your validated test actually does or does not improve clinical outcomes for patients.
All right. So yesterday we discussed a little bit about interpretation of these reports. Let's start with mosaics, and then how do we, like, is there a cutoff? What to do if my lab gets a mosaic embryo? How should I counsel my patient? And any guidelines that we should follow?
So I think that one of the challenging things with mosaic embryo diagnostics is that with the advent of next generation sequencing, these intermediate copy numbers were seen, and this automatic diagnosis of mosaicism was applied to these intermediate copy number findings without ever actually knowing what clinical implications those intermediate copy numbers had. There have been subsequent studies which have been done which have looked at these intermediate copy numbers. One of the ones by Teagues et al. Was a non-selection study, meaning that the diagnosis of intermediate copy number was not shared with the patient or the clinician. They opted not to get that information.
Yeah.
And then subsequently, the retrospectively was looked at. The outcomes were already known, so they were either pregnant, not pregnant, or had a miscarriage. And we looked at whether or not the intermediate copy number was present or absent. And it turned out that the live birth rate did not vary between patients that had no intermediate copy number or mosaic diagnosis versus those that did. So I think that we're learning that mosaicism may ultimately not be as impactful as was once thought or been concerned about.
Yeah, because this, like, even if I talk from the patient's perspective, they have access to the internet. They come across all sorts of articles saying huge litigation on a specific group of clinics because they discarded embryos which could have resulted in a normal birth. Which, I mean, we're falling in that particular zone right now where a litigation could be possible if the embryo is discarded. So, do we have any sort of a guideline for us that tells us, okay, for so and so, like a percentage cutoff of mosaicism where we can use the embryo, or so and so chromosome mosaics we could use it. I think PGT-A has something like that.
So PGT-A has input in terms of the low mosaic embryos ought not to be classified as fully aneuploid, and they have information about how it ought not to be discarded. I think that one of the really challenging things that we're seeing is that in some ways, some of these diagnoses were put into place without knowing the real clinical implications. And we're learning that perhaps mosaic embryos are not embryos that are reproductively incompetent and may not truly have any increased risk of untoward outcomes in the pregnancies themselves or the live birth themselves.
Yeah. Any data on concordance for mosaic diagnosis of tracheotomy biopsy with the inner cell mass?
Yeah, so there have been some rebiopsy studies that have looked at concordance. That's one of the ways that you can evaluate or analytically evaluate your PGT platform. One of the analytic validations is with cell lines, known monosomies or trisomies. The other's with rebiopsy studies. One of the challenges, or one of the benefits with rebiopsy studies, is you're dealing with biopsy specimens as opposed to genomic DNA with cell lines. One of the other challenges is that you can prove that you have concordance. Discordance is difficult to know if it is an assay issue or if it's true mosaicism.
So, let's say I've done a rebiopsy. I have one a result of segmental aneuploidy, the other result, and this from my understanding is common. The second result comes as a mosaic. Now, or should I consider both of the biopsies together to come up with a final report?
I think that is really one of the challenges with clinically rebiopsying embryos. So for my patients, if they have a diagnosis that is made of mosaic, I don't recommend rebiopsying the embryo because once you rebiopsy, you're left with two concordant results, which is possible, in which case you can be reassured of your original diagnosis. If you have discordant results, which do you believe?
Yeah, exactly. I was reading a publication where it was mentioned that certain areas of the trophectoderm could have a certain population of mosaic cells versus normal cells. So, is there a way to choose the right cell for
For
diagnosis, for
biopsy?
biopsy?
I don't know that there is a great way to choose the best biopsy site for a
Yeah.
trophectoderm biopsy, unfortunately.
Yeah, it is challenging. Um, okay, coming to the next part, which is segmental aneuploidies. Could you define it, and could you chalk out a path for these embryos for patients?
Yeah, so I think segmental aneuploidies are a little bit more challenging than mosaic embryos just because presently we have a lot less clinical data for outcomes with embryos that have had segmental aneuploidies diagnosed with PGT and outcomes.
Yeah.
We have a lot more papers that are out there and more coming out all of the time which show that mosaic embryos diagnosed with PGT have healthy live births. There are fewer studies with segmental aneuploids, and I think that one of the other concerns is that there are clinical diagnoses which are made that have segmental aneuploid results that result in syndromes with children.
Yeah.
Much less likely with mosaics. There aren't, to the best degree we can tell, mosaic individuals walking around out there, or perhaps we're all mosaic in
Yeah,
some
probably.
regard. But with segmental aneuploids, we do see that with pieces of chromosomes missing or in excess, that actually can result in a child which does have a known issue.
Yeah.
And I think for those individuals, it is more challenging. For the clinical management of those patients, I oftentimes will have those individuals meet with a genetic counselor to review the portion of chromosome that is missing or in excess, to review the most current literature to see if there is any known syndromes with that portion of the chromosome.
Now, again, what I've read about segmental mosaics, I think I asked you last evening as well, that rebiopsy for these have resulted in a lower concordance with the nasal mass biopsy. Um, Not rebiopsy, but when you're looking at the nasal mass concordance for segmental aneuploidies, it's lower. So, is this reassuring or?
Well, I think that one of the things we do know about segmental aneuploidies, from what we can understand, they appear to be more meiotic or mitotic in origin rather than meiotic. So, of the studies which have been done with rebiopsy, they have been reclassified as mosaic segmentals rather than full segmentals. So, I think that I don't know how reassuring or non-reassuring that is, but I think it does speak to a potential different biologic origin than some of the other mosaic embryos, whole chromosome mosaic embryos that we think about.
All right. I think last question that I'll ask you would be non-invasive preimplantation genetic testing. Again, I know that concordance is not out there. Like, will be about 90-95%, if I'm not mistaken. But when I was reading a few papers, it said that the concordance is better with whole blastocysts as compared to just a trophectoderm or the nasal mass. So, looking at that, would non-invasive, when we are comparing it with the whole blastocyst, is that something that we are wanting to achieve because it's giving us a larger picture? It's just not the trophectoderm.
Right. Well, I think that one of the things, obviously, when it comes to PGT, the holy grail is non-invasive.
Yeah.
There have been several studies which have shown that the impact of an embryo biopsy does not impair the chance of that embryo producing a pregnancy. Difficult to know if there are any other potentially untoward interactions, and thus ideally I would say non-invasive PGT would be great. The concern that I have, as you noted, is the concordance with non-invasive PGT when they look at trophectoderm biopsies, and the concordance of results is very disparate. I don't know if yet we are at a point where we are ready for non-invasive PGT as prime time. Perhaps more of a rank order rather than a true black and white discard versus transfer.
Like to prioritize
Perhaps.
for biopsy.
Perhaps.
Okay, thank you, Jason. If you could just give the viewers maybe 3 learning key takeaways from your lecture.
Sure. I mean, I think that some of the most important things are knowing the PGT lab that you utilize, knowing what they have undertaken in terms of analytic and clinical validation, and then also having a good handle on clinical utility. I think that mosaic embryos, there is increasing data showing that mosaic embryos do not in fact impair the chance of a live birth with transfer. Segmental aneuploid embryos, I think that the jury is still out. I think we need more data in terms of what the outcomes for these segmental aneuploid embryos are.
Thank you, Jason. And for more content like this, do subscribe to our YouTube as well as our Spotify channel, and do follow us on social media. Thank you. Awesome. Thank you.